Timurthy for giving me this opportunity. I've been asked to talk on the surgical technique of standard suture fixated posterior chamber lens, that is scleral fixated lens. I have no financial interest in the product. Why we should go for a posterior chamber scleral fixated IOL? So we all know that posterior chamber is the normal anatomical position of a human crystalline lens, and since it is away from the endothelium, there is less chance of damage to the endothelium and subsequent bullous keratopathy, and there is decreased risk of damage to the angle structures, which can reduce the incidence of secondary glaucoma. And there is decreased risk of pupillary block glaucoma, there is decreased risk of pseudophacodonesis, and the lens is closer to the rotational center of the eye, so it reduces the centrifugal and thus it reduces CME and iritis. And one more thing is it is closer to the nodal point of the eye, so obviously it will give better optical quality of image. But before practicing this scleral fixated posterior chamber IOL, one should know the normal anatomy of ciliary sulcus. So there was one study by Duffy, which was published in '89, which showed that the ciliary sulcus is wide in the vertical meridian, that is 6 to 12 o'clock axis, and it is narrow in the horizontal axis. This one should know. Video? This animation shows the location of ciliary sulcus, which is behind the iris, and you can see the distance from the corneoscleral limbus to the ciliary sulcus. One should know the exact location of ciliary sulcus before practicing this procedure. And there was one more study which was done by Holland, Edward, which showed that the ciliary sulcus is 0.8 millimeters away from the corneoscleral limbus in the vertical axis, and it was only 0.46 millimeters away from the limbus in the horizontal axis. Lens is a PMA lens which is 13 millimeters in overall diameter, which has got an optic of 6.5 millimeters and 2 haptics, and it is an equiconvex optic, and 2 haptics with the eyelets on either of the haptics for iris fixation of the sutures. And after, it should be done ideally as a secondary procedure. When once the eye is quiet, the results will be much better. And after creating scleral flaps or scleral tunnels, preferably in an oblique axis, not exactly on the horizontal axis, 26 gauge needle is passed, and similarly straight needle is passed from the opposite side, which is passed through the barrel of the 26 gauge needle and brought out from the opposite side. You can see a segment of polypropylene suture, and then which is extending from the limbus to limbus, which is brought out with the forceps through the main incision, and then it is cut in the middle and sutured to the eyelets of the lens. The tightness should be adequate. It should not give way. And here we are showing a nano polypropylene suture which is tied to the inner aspect of the eyelet. And once it is done, the lens is passed through the main incision, sclerocorneal tunnel, into the ciliary sulcus. And then it is rotated to position, and the sutures are tied. Sutures are pulled and tied on the floor of the tunnel, or scleral tunnel, or under the scleral flap, whatever it is, with the adequate force. And this is just to show the suturing techniques Dr. S.K. Rao is going to deal with in the next topic. So, and at the end of the procedure, you close the conjunctiva either with the sutures or with the glue, and remove all the viscoelastic substance and give subconjunctival triamcinolone or dexamethasone. So, but scleral fixated posterior chamber lens is not, it's associated with certain specific complications in addition to the complications which we encounter in a standard IOL procedure. These specific complications like IOL dislocation, which is seen in scleral fixated sutured IOL, this could be because of bio disintegration of the tennopolypropylene sutures. To avoid this, you can use nano-polypropylene sutures, which can reduce the incidence of degradation or IOL dislocation. You have a complication of IOL tilt, you can see here, which can happen in a 2-point fixation, which can be largely avoided by going for a 4-point fixation procedure. And suture erosion is common with the sutured posterior chamber scleral fixated IOL. This can act as a tract for the infection to go into the inside of the eye, and this can be largely avoided by sliding the sutures under the flap or under the tunnel. And hemorrhage is common if you go beyond 1.52 millimeters beyond the limbus. It can happen, and other complications like increased IOP, CME, RD, uveitis are common with this procedure. There are various studies which have confirmed the efficacy of this procedure, and one study has proved that secondary IOL, SFIOL has a lower complication rate compared to the primary, and SFIOL is a safe procedure with a small risk of significant complications. And before I conclude, I would like to give some practical tips on this procedure which can improve the outcome of the procedure, and if possible, do it as a secondary procedure, possibly after 6 weeks of the primary procedure. This can reduce the incidence of complications like CME or RD or other complications, and do adequate vitrectomy before putting in this scleral fixated IOL. This can reduce the chance of tilting of the lens and other posterior segment complications, and do this vitrectomy after creating a sclerocorneal tunnel or a scleral flap. Otherwise, in a hypotonous eye, it is difficult to create a flap or a sclerocorneal tunnel. As far as possible, avoid horizontal placement of these sutured IOLs because you are going to damage the long ciliary nerves and long ciliary arteries. And don't go too far posterior. You know the anatomy of ciliary sulcus. It is ideal to pass the sutures at around 0.8 to 1 millimeters behind the limbus. And nano-polypropylene suture is better than 10-polypropylene. Yeah, I am concluding this. And cover the knots with adequate tightening. Thank you very much.
Thank you, Dr. Sureesh Kumar, for very elegantly showing how a 2-point fixation with the sutures can be made. Tightening.
Thank you very much.